Today we will be discussing on diabetic nephropathy. Diabetic nephropathy is a topic and I'm not going to the aspect of diabetes. It's beyond the scope of today's discussion. But today we will be discussing on the key aspects of diabetes. What are the drug modifications that is required when a patient have rising creatinine, when the patient is having proteinuria, and what is the basic concept of diabetic nephropathy, and what are the basic evaluation that has to be done in a case of diabetic kidney disease, and articulate the interventions, medications, lifestyle, diet that may reduce albuminuria and retard the progression to end-stage renal disease. So, what exactly is the magnitude of this problem? Yes, diabetics is the leading cause of end-stage renal disease. It's the leading cause of non-traumatic limb amputation and preventable blindness. Nearly 425 million adults suffer from diabetes worldwide, and this number may go up to 600 million by 2045. And diabetic kidney disease has a good association with type 1 diabetes, where nearly 30% of type 1 and type 2 diabetes, nearly 40% will have renal dysfunction. The metabolic syndrome, characterized by insulin resistance, obesity, hypertension, dyslipidemia, and high triglycerides, usually follows type 2 diabetes. The most aerated drinks or those drinks now available which has high element of fructose actually precipitates these metabolic syndromes and creates an elevated uric acid level. There are a lot of studies that have proved that raised uric acid level is a mark of type 2 diabetes. It's an early marker of a type 2 diabetes and gradually diabetic nephropathy. The type 1 diabetes patients with first degree relatives with diabetes and diabetic nephropathy has nearly 83% chance to develop diabetes in them. So diabetic nephropathy in them. What are the common complications that we see? The common complications when you see will be the cardiovascular disease and the peripheral neuropathy. But yes, 2% of the patients suffer from diabetic nephropathy. But this 2% has actually end up in dialysis and increased cost of healthcare. So the management of CKD in diabetes never only focused on the kidney, but must also involve the proactive intervention, early detection, and effective treatment of all diabetic complications. So diabetic kidney disease is not just all about the kidney. Those who have a creatinine or a raised urea levels or creatinine levels or diabetic nephropathy will definitely have other associations like cognitive impairment. They have high chance of cerebral vascular disease, coronary artery disease, diabetic cardiomyopathy, eye disease, neuropathy, bladder dysfunction, erectile dysfunction, eye disease, and even depression and anxiety has been associated with chronic kidney disease. Now, what about association with other disease? Rising creatinine has been given a special respect in all sports, whether it is in the intensive care unit or whatever score you put in ICU, whether the Apache score or any intensive care score, you can see that rising creatinine will increase mortality significantly. So when a patient is having a CKD, there is increased chance of CVA, acute myocardial infarction, and congestive heart failure when compared to those who is having a normal kidney function. And even in our unit, nearly 80% of the patients who are right now in dialysis is because of diabetic nephropathy, followed by hypertension and cystic kidney disease, and glomerulonephritis contribute only a very smaller component. What is the epidemiology of disease in Indian scenario? In the Indian scenario, type 1 and type 2 diabetes occurs a decade earlier than in the West. And it even occurs in non-obese individuals, but pediatric or childhood type 1, type 2 diabetes is less common in Indian scenario when compared to the West. And Indian diabetes patients are more prone for cardiovascular disease when compared to those in the West. India being the diabetic capital of the world, followed by China, where you have nearly 72.9 persons with diabetes in millions. And we have Kerala being the leader of diabetes in India. In Kerala has the maximum number of diabetic patients, where we have a heavy load of patients in Pathanamthitta due to various reasons, maybe diet and their lifestyle. And 50% of the people with diabetes remains undiagnosed. So there is a component of people who doesn't know that they are having diabetes, and by the time we diagnose them, they will have almost every complication mentioned in the list. We do have patients who presented to us with advanced renal failure and who was detected to have type 2 diabetes for the first time when they presented to us. So what happens to a damaged kidney? Damaged kidney, the filter is damaged and it allows more albumin to cross the barrier into the urine. The increased glomerular permeability allows albumin, and this reaches the urine, and higher levels of protein is excreted in the tubule. The tubule usually absorbs almost a good amount of protein that is excreted, but since the quantity is so high, the tubules are not able to absorb this urine, and it is excreted outside. What happened in diabetic glomerulopathy? In diabetic glomerulopathy, it is one of the conditions where usually in kidney disease, the kidney shrinks. But in diabetic nephropathy, the kidney enlarges. There will be nephromegaly, the glomerulus will be enlarged. And there will be enlargement with increase in the mesangial cells. And the hallmark will be the mesangial expansion with nodular diabetic glomerular sclerosis, which we call the Clemensstiel-Wilson lesions. And finally, the kidney, entire glomerulus goes into a sclerosis, and patient will start developing kidney disease. Nearly 50% of the renal function or 50% of the glomerulus is lost. Urine albumin is a marker of kidney disease. Normally, you and me will be expecting 150 milligram of protein per day, of which 30 milligram will be nearly albumin. Urine albumin definitely is a marker not only for the kidney disease. Newer studies have shown that cardiovascular disease is also associated with albuminuria. And urine albumin to creatinine ratio is a simple technique to determine the level of urine or quantify the level of urine, which help us to assess the improvement in treatment or progression of the disease. This is basically the ratio between the urine albumin and the urine creatinine, which actually nullifies the effect of diet which the patient has taken, or because sometimes the diet, high protein diet, may increase creatinine. So a urine albumin creatinine ratio of less than 30 milligram is generally considered as normal. The term albuminuria describes all levels of urine in albumin. Initially, we used the term microalbuminuria when the urine albumin is between 30 milligram and 300 milligram, and macroalbuminuria when it's more than 300 milligram. But nowadays, we use commonly abnormal UAE, abnormal urine albumin excretion. So there are a lot of studies. I'm not going to bore you with numbers, nor I'm going to bombard you with statistics. But yes, we have a lot of studies that has actually shown that lowering urine albumin creatinine ratio may lower the risk of progression of kidney disease. And a lot of medications has been hypothesized that will have this effect, which we will be discussing in later slides. Hyperglycemia is associated with hyperfiltration. Yes, this is another important concept of diabetic kidney disease, where many times the patient will come to us and say, sir, I'm diabetic for so much of years, and look, my creatinine is only 0.9. But initially, in the initial stages, what happens is that there will be hyperfiltration, and the creatinine will come down from 1.2 to 1.9 and 0.8 because of this hyperfiltration. This is not a good sign. So when the patient comes to you and saying that my kidney is absolutely normal with a 0.9 creatinine, it is actually a marker of an impending rising creatinine, impending CKD the patient is going to face. So whenever you see a patient with low creatinine at somebody at the age of 40 or 60, definitely think about that. He's in a stage of hyperfiltration, especially if you have diabetes, and start counseling him to prevent proteinuria, start counseling him to prevent the onset of a CKD. Screening for diabetic kidney disease. When should we screen? In the type 1 diabetes, yes, it is usually diagnosed very early, and it can be actually screening can be done after 5 years of type 1 diabetes and maybe annually thereafter. But in type 2 diabetes, there is a population which actually have never known that they are having diabetes. So in the first instance itself, when you diagnose a diabetic patient, type 2 diabetes, you better screen for a microalbuminuria. If negative, repeat it annually. And if positive, you have to make sure that 2 or 3 specimens will have this proteinuria before you confirm that the patient is having microalbuminuria. And the urine should be non-ketotic and sterile. What are the basic evaluations that's required? So there is no picture planning to do for every patient. You tailor it for the patient. So the basic Panel includes glucose, creatinine, blood urea, nitrogen, electrolytes, albumin, calcium, phosphorus, and even CBC is important in diabetic patients. Studies have shown that even mild anemia will increase the risk of progression of diabetic nephropathy. So treatment of anemia in renal failure may slow down the progression and decline of renal function. So hemoglobin has an important component in preventing the progression of diabetic kidney disease. And HbA1c, yes, HbA1c is a marker of how well the patient has controlled diabetes in last 3 months. And the UK study has actually showed that reducing HbA1c levels by even just 0.9% will reduce the risk of developing diabetic nephropathy very considerably. And last but not the least, whenever you see a patient with proteinuria and he's a diabetic patient, don't think that is all diabetic nephropathy. No, diabetic nephropathy patient can have proteinuria due to various other reasons. They can also have the disease like multiple myeloma, or they are having other glomerulopathies, which also present as proteinuria. So all proteinuria in diabetic patient may not be a diabetic nephropathy. So always keep in mind the possibility of a differential diagnosis when you see a patient with proteinuria in diabetic settings. Management. I'm not going to elaborate on the entire management of diabetes, yes, but those which has got some renal specific aspect. So first thing is ensure the diabetes, the diagnosis is correct, it's diabetic nephropathy and it's not other causes that is resulting in proteinuria. And modify OHs. Yes, we'll be discussing with your side that every drug has got a renal dose adjustment, and OHs is a drug that has to be modified once the patient start having a rising creatinine. And definitely screen for CKD complications and educate the patient about the diabetic kidney disease, treatment options, and renal nutrition. It's also an important component. What to eat, what not to eat when the patient is having a rising creatinine. And in advanced stages, you should start counseling the patient for renal replacement options. So, what are the interventions of reducing urine albumin? The first and the foremost, control the blood pressure, reduce sodium, achieve good control of diabetes early, reduce weight if obese, reduce protein intake, and achieve tobacco cessation. Initial stages, we usually advise on protein restriction. As the creatinine rises, as the CKD advances, we reduce the protein to 0.8 gram per kg per day. Protein restriction has been found to delay the progression of CKD. So, in the worst part is that many times you can see a lot of protein powders being pumped into kidney patients, which is worsening the renal function. So, in an advanced CKD, in a patient with rising creatinine, always make sure that the protein is restricted and no protein powders are pumped in. Advanced trial. This is one of the trials in which we compared 81 patients who received both intensive glucose control and 120 patients who has not received an active intervention or a standard glucose control. At the end of the study, what they found out is that there is a 3+ relative risk for new or worsening nephropathy with standard glucose control. In advanced study, the intensive glucose control for a 5 years significantly reduced the risk of developing nephropathy by nearly 21%. The blood pressure control also reduces the renal events by another 21%, particularly in terms of new onset microalbuminuria. There is something called a legacy effect in diabetes. The legacy effect is that you have a diabetes patient, you see the patient for the first time. In the first 10 years, you make sure that the patient is in strict diabetic control. You make sure that his HbA1c levels are optimal. He has got the best diabetic medications, diabetic control. In the first few years, the legacy effect will be there. Even after 10 years, when this diabetic control loses, the chance of he developing complication is much less, which means that a diabetic patient in the first few years of life is most important. And many times, this first few years of life, the patient will be following up with the primary physician, not with the nephrologist. And angiotensin receptor blocker, receptor antagonist, and there have been a lot of studies worldwide that the ACE inhibitors considerably reduces the proteinuria and progression of CKD. ACE inhibitor is a double-edged sword. The problem is that the minute you start on ACE inhibitor, there is a mild probability of rising creatinine. So many times the patient walk-ins, we start on ACE ARBs, then the rising creatinine, the patient will be unhappy. The patient will feel after seeing you the start, there is a rising creatinine. Yes, up to 30% rise in creatinine is acceptable when you start on an ACRB. But the long-term benefit of ACRB, where it reduces the proteinuria, it reduces the progress to end-stage renal disease, has to be explained in the first instance in itself. And the patient should be also told that there might be a mild rise in creatinine with this drug. And there is a chance of hyperkalemia, especially in CKD settings. In CKD settings, the chance of hyperkalemia is high, so that the patient is advised to reduce on fruits and coconut water and coconut added items, so that hyperkalemia is avoided in those with ACRBs. So another group of drug is basically the SGLT2 inhibitors. There have been a lot of trials coming out on SGLT2 where the sodium glucose transport on the proximal loop of proximal convoluted tubule is inhibited, and there is not only, it's all about controlling the blood sugar. It has an impact on the cardiac function. It also increases the erythropoietin levels, and it also increases the anemia. And SGLT2 has now been shown to have benefit not only in the renal aspect but of the cardiac aspect, and in a lot of other aspects of care of diabetic patients. So most drugs have a renal dose adjustment. Metformin, yes, it is one of the best drugs. It's one of the cheapest drugs. Any patient on type 2 diabetes with normal renal function should be on metformin. But the metformin problem is that once you start metformin, many times the primary care physician forget to follow up the creatinine levels. Over a period of time, the patient's creatinine will be starting, they will be rising in the creatinine, and metformin dose has to be reduced when the eGFR reaches 45, and it has to be discontinued when the eGFR is less than 35, which is many times missed. And most patients on metformin over a period of time will develop complications because the dose is not adjusted. Even though the chances of lactic acidosis caused by metformin is less, the most common will be anemia because of the associated vitamin B12 deficiency with metformin. In sulfonylureas, very few sulfonylureas are actually safe in advanced CKD. Maybe glutazide and glimepiride, but most other sulfonylureas like glibenclamide, glimepiride has to be avoided. The alpha galactose inhibitors, acarbose, vobibos, better to avoid because it's known to raise creatinine levels. The PPG group is routinely not recommended because it increases the edema and weight gain, and we may not be able to differentiate why it's because of the renal dysfunction that the patient is developing edema or because of the blood per se. The DPP-4 inhibitors, yes, almost every DPP-4 inhibitor is being metabolized by the kidney, and in CKD setting, the safest being linagliptin, which is actually been metabolized in the liver. And Lina scores out the SASA only in aspect of that it doesn't require a renal dose modification. Sasagliptin can also be tried on modified renal doses. So, other glucose lowering drug, the newer being the GLP-1 receptor antagonist and this receptor agonist. These drugs, except dulaglutide, most of the drugs has got a renal dose adjustment. And incretin mimetics, semaglutide, which is now available in oral form, is also considered to be safest. Now, what about achieving glycemic targets using insulin? Insulin undergoes a first-pass metabolism in the liver, and 40% of the insulin is being excreted by the kidneys. So, as the renal function worsens, the metabolism of insulin is actually affected, which means that even for the same dose insulin when the patient is stable, the patient may go to hypoglycemia when the renal function deteriorates. So there should be a titration of the dose of insulin, and many times when the patient goes to dialysis, the endogenous insulin secretion may be enough, and we may be able to discontinue insulin in patients with advanced renal failure. So a patient who comes to you with hypoglycemia, with who was on stable insulin, should always be counseled or always be checked for a worsening renal function. Then there should be a holistic approach. Diabetes management is definitely not a one-man show. you should have the dietitian, and physical activity of nearly 150 minutes per week is required. You have to advise on smoking cessation, weight management. Along with that, the drugs plays an important role, of which ACRBs and SGLT2 receptors has got a major role. And yes, in indicated cases, low dose platelets and statins has to be added to provide stability in renal function. And regarding the newer non-steroidal mineral corticoid receptor antagonists, Pindrinone, there is a lot of studies has been coming out on the role of spironolactone upon epinephrine, which are actually steroidal mineralocorticoid. But the recently Pindrinone, it's a non-mineralocorticoid receptor antagonist, has been found to have a favorable effect on worsening the renal function in CKD cases. And when should you refer to a nephrologist? Yes, when you need assistance to prepare the patient for a renal replacement therapy, you feel that there is something missing in the case and the proteinuria is not purely because of the diabetes, and there is a rapidly progressive renal failure where the eGFR fall is more than that is expected, and you need assistance in managing other complications associated with CKD like blood pressure, anemia, CKD, MPD, middle-bone disease, hyperkalemia, hyperphosphatemia, and secondary or tertiary hyperparathyroidism. And when the patient has AKI on CKD due to some illness or some stress. And why treat advanced CKD? Yes, we cannot substitute an organ that is lost, whether it is the damaged liver or it's an amputated toe or it's a damaged kidney. Retard the progression of the disease. We prevent the delay and progression to dialysis. We can prevent other complications like blindness and amputation. And we can actually improve the quality of life and reduce the cost of care of end-stage renal disease patient. So, summarizing, the CKD doubles the risk of cardiovascular events and death in patients with type 2 diabetes. It's never too late to improve the glycemic control, but definitely the strategy is different in CKD cases. CKD should be considered when choosing an anti-diabetic. Stage of CKD should be considered when choosing an anti-diabetic therapy. Avoid hypoglycemia. Many changes of treatment are needed, making management challenging in chronic kidney disease patients. Okay.
Thank you, for the excellent and very explained of the diabetes. The topic is common for this. Is there any genetic marker for predicting diabetic nephropathy very early ahead of a patient with diabetes?
So type 1 diabetes definitely has a genetic indicator. Type 2 diabetes doesn't have a genetic doctor associated. But yes, there are a lot of markers that has been done that again, nothing is confirmative, but yes, uric acid has been considered as a marker of type 2 diabetes. Except with type 1 diabetes, you don't do a genetic test because we cannot see type 2 diabetes.
And is there any harm in taking extra protein for normal without diabetes? With diabetes is the normal.
So too much of protein is definitely not. Because protein don't require for there is always a combination of diet and of protein. Many times we get those chaps to go to the gym where they take a lot of protein powder and we have the issues of this proteinuria renal disease coming. So usually high protein diet is not favorable for the kidneys.
With type 1 diabetes, 30% there is a death of kidney disease. So the average will be kidney disease type 1.
So most of the diabetes will develop by 5 to 10 years. The type 2 is around 10 years. Type 1 will be mostly fixed as a so the nephropathy incidence will be because of the younger age, they are type 4. The most kind of treatment will be definitely needed. So the incidence of type 1 diabetes is less because of the high quality care that is there. In type 2 diabetes, nearly around 7 to 10 years, definitely
Yeah. But there will be pre-diabetes. There is pre-diabetes.
Why there is this subject always dissociates our previous time was we nowadays we are seeing so many normal and high.
Yes. There is disproportionate urea. You can see in JMB. Somebody is having an peptic ulcer. There will be definitely bleeding from the stomach, and the urea will be high, and the iron will be low. And stage of intramuscular body reacting to be normal. So urea has got an implication on the GMP. It has an implication on the body stats of the patient. Yes, creatinine do have an implication on the muscle mass of the patient. So when a patient is having a high muscle mass, creatinine may be 1.5. Once I monitor my carriers come out 1.2. The first thing you check is how much weight the patient has lost. So when the muscle mass comes down, creatinine also comes down. So it's because the dissociation comes because of the other parameters associated, not because of the fluctuation in function.
So in old ages, we should address creatinine the photographing compound.
So creatinine, there is a loss of GFR of 10 ml per minute immediately after 40 years, even you have the calculations. So by giving there will be an acceptable regeneration of it. But if you take a 70 or 80 years, the possibility of creatinine in 1.3 or 1.4 is natural. Because the GFR, there is a degeneration of glomerulus from the age of 40 years till the 80 years, around 10 ml per 1.7 meters per every decade. So, in my pricing creatinine, as age advances, is accepted. All it depends on stage of business. The reason we definitely go with my body, but once the GFR comes down, I will definitely take it because I have new pride. Along with maybe grants which will help me. And I will have a example to provide me some saving to the past. The offer yes, the early phase provided that the GFR is going to your interpretation that we should not start like that only. But still, I may not start in like that. But still, actually, I is one of the early objects of the advance. Usually, when it's giving zone some kind of I use basic support all the time. But I give a long activity at night time. And I support the yeah, I use largely. Something largely as a long active. And I support the
No more questions. We might have seen. Then we go to the price distribution.
Man of the series, Dr. Nasser. D.N.B.